Namaskaram, dear friends. The Global Initiative for Asthma, that is GINA, came up with its latest guidelines on bronchial asthma way back in the months of February or March this year. I have summarized the same over here. I urge you watch the video till the end as a ready reckoner of key changes have been provided over there. But prior to that, if you are someone who wants to stay updated with the latest in pediatrics, have crystal clear concepts, get a succinct summary of most of the topics, you register better with illustrations rather than simply reading text, and you want a rapid and reliable reckoner, then this is the place for you. You must subscribe the channel of PED for PGs and GPs, because here you will be abreast of latest guidelines and recommendations in the field of pediatrics. Get your concepts both in basic and advanced pediatrics clarified, and you will also learn the demonstration of important clinical examination skills. Coming on to the GINA guidelines, the diagnostic flowchart for clinical practice has been revised in the sense that it allows for the selection of different initial lung function tests depending on the local resources. Like for example, the earlier GINA guidelines mentioned spirometry to be used for measuring lung functions, but now the diagnostic flowchart also mentions the use of peak expiratory flow rate monitor, that is PEFR monitor, for measuring the lung function tests in the initial diagnostic flowchart. This is the diagnostic flowchart, and here you will see that not only spirometry but even PEF has been recommended, especially in places where the resources are limited. The criteria for identifying variable expiratory airflow limitation have been clarified with more details about bronchodilator withholding. What does this mean? So we know that asthma has a variable expiratory airflow limitation because it responds to bronchodilators also. So the following are the criteria by which we can assess the variable expiratory airflow limitation. First is the positive bronchodilator responsiveness. Next is excessive variability in twice daily peak expiratory flow rate monitoring over 2 weeks. Third is increase in lung function after 4 weeks of treatment. Fourth is a positive bronchial challenge test, and fifth is excessive variation in lung function between visits to the hospital. So the criteria for identifying the objective parameters which have been mentioned by the GINA are as follows. What we are seeing, we are basically focusing on children. So a positive bronchodilator responsiveness with spirometry or PEF is defined as FEV1 of more than equal to 12% of the predicted, or PEF more than equal to 15% of the predicted, measured 10 to 15 minutes after administration of 200 to 400 micrograms salbutamol. And we know that 1 puff of salbutamol is 100 micrograms. So after administration of 2 to 4 puffs of salbutamol, if there is an increase in FEV1 of more than equal to 12% of predicted, or increase in peak expiratory flow of more than equal to 15% of predicted, then we say that the patient has a positive bronchodilator responsiveness and he may have asthma. Then the second thing is that details have been added about bronchodilator withholding. So before performing these tests, if the patient is already on some medicine, we have to withhold these medicines for certain duration. Like if we are performing the test and the patient is on SABA, that is short acting beta agonist, then we have to withhold SABA for at least more than equal to 4 hours and long acting bronchodilators for 24 to 48 hours, because this is the half life of these drugs. The next criteria is excessive variability. So the excessive variability, average daily diurnal PEF variability, if it is more than 13% in children, then there is a possibility of bronchodilator responsiveness, expiratory airflow limitation. Then increase in lung function after 4 weeks of treatment if it is more than 12% of predicted in FEV1 or more than equal to 15% of predicted in PEF. Then we also may think that the patient has bronchospasm, expiratory airflow limitation. A positive bronchial challenge test means that a fall from baseline in FEV1 of more than equal to 12%, or fall in PEF of more than 15% with standardized exercise challenge test, and excessive variation in lung function between visits is more than equal to 12% in FEV1 or more than equal to 15% in PEF. So this has been added by the GINA. Bronchodilator responsiveness, as we have already learnt by now, is change in lung function which is seen 10 to 15 minutes after administration of 200 to 400 micrograms, and that is 2 to 4 puffs of salbutamol, and the bronchioles are referred to as responsive to the bronchodilator if there is an increase in FEV1 of more than equal to 12% of predicted, or in PEF more than 15%. So the GINA has given this criteria for indicating bronchodilator responsiveness of the airways, but the American Thoracic Society and the European Respiratory Society Technical Standards Committee take the criteria as increase in FEV1 of more than equal to 10% compared to 12% by the GINA. So GINA is still reviewing the recommendations by the ATS and ERSTC and has yet not adopted the same, but is thinking of adopting the same. More information has been added about cough variant asthma. It is basically a clinical phenotype of asthma presenting only with cough. So what is meant by phenotype? Phenotype is the physical representation of an illness. Some other examples of phenotypes of asthma are childhood onset asthma, adult onset asthma, obesity related asthma, aspirin related asthma, and so on and so forth. So now I guess you have an idea what different phenotypes of asthma are. So cough variant asthma is also basically a clinical phenotype of asthma. There are certain other differential diagnoses which present only with non-productive cough. So besides cough variant asthma, there can be chronic upper airway cough syndrome characterized by post-nasal drip, cough induced by ACE inhibitors, gastroesophageal reflux, chronic sinusitis, post-infectious cough, inducible laryngeal obstruction, and eosinophilic bronchitis. Spirometry may be normal, or variable airflow limitation may be identified only by bronchial provocation testing. Otherwise, hyperresponsiveness is generally not apparent in patients with cough variant asthma. Some may later go on to develop wheeze and bronchodilator responsiveness. Then, how do we say that cough is due to asthma and not otherwise? What distinguishes these patients from other differential diagnoses of non-productive cough is the fact that most of these patients have sputum eosinophilia, and they may also have elevated fractional excretion of nitric oxide. What is this? We will be seeing later. The cough may reappear, so you need to give inhaled corticosteroids to these patients, and the cough may however reappear if inhaled corticosteroids are stopped, and this is also in retrospect a proof of the diagnosis of cough variant asthma. The treatment follows the usual recommendations of management of asthma in children. To assess the symptom control, that is the control of symptoms in a patient, we look for 4 things. And these 4 things are the daytime symptoms of the patient, the nighttime awakenings of the patient, the frequency of use of reliever medications, and any activity limitation when in the past 4 weeks. We are looking at in the past 4 weeks only. So this is how we assess whether or not the symptoms of the patient are controlled. So this assessment should not be limited to last 4 weeks only as per GINA 2024, and it should be looked further even beyond that, even though recall error might occur with even longer durations. Besides assessing symptom control, one must also assess the risk factors of the patients for future exacerbations. So what are these risk factors? There are 2 kinds of risk factors for future exacerbations. They can be modifiable risk factors and non-modifiable risk factors. Modifiable risk factors are, for example, exposure to smoking, disease, exposure to dust, etc. And non-modifiable risk factors are history of severe exacerbation requiring hospitalization, PICU admission, or even intubation in the past 12 months. Besides symptom control and patient's risk factors for future exacerbations, one must also look for any decline in lung functions. This means that if possible, the patient should be subjected to pulmonary function testing at the follow-ups, and any side effects of the medications which the patient is already on. In patients who are not taking inhaled corticosteroids, serious exacerbations are associated with a greater decline in lung functions, And therefore, what is important, the whole stress of GINA in 2024, as has been in the previous 2 years GINA guidelines also, is to use inhaled corticosteroids, and inhaled corticosteroids both as maintenance and reliever therapy. GINA's goal of treatment includes long-term asthma symptom control. This means that the patient should have few or no asthma symptoms, should have no sleep disturbance due to asthma, and there should be unimpaired physical activity. But besides this long-term symptom control, GINA's goal of treatment also is to minimize the risk of future exacerbations. So this includes no exacerbations, improved or stable personal best lung function, that is no decline in lung functions on subsequent visits, no requirement for maintenance systemic corticosteroids. Here you must remember, you must understand very carefully that inhaled corticosteroids have local action only, that is the respiratory system, and systemic corticosteroids have a systemic action, they have a higher dose, and they are more likely to subject to make the patient prone for side effects. And therefore systemic corticosteroids, like previously we used to give prednisolone for 5 days 7 days to go off the to let during the period of flare up or exacerbation, but now the stress is on to decrease the use of systemic corticosteroids and increase the use of inhaled corticosteroids. So if there is no requirement for maintenance systemic corticosteroids, this should be our long-term plan for risk minimization, and there should be no side effects of the medications. So when discussing the possible outcomes with the patient, one must also consider their goal of treatment, which includes their goals, asthma phenotype, clinical features, multimorbidity. This is a new term which has been coined by GINA 2024, because in most of the other places, like in previous GINA guidelines also, the term used was comorbidities. Multimorbidity, because asthma generally most of the time does not occur in isolation. Atopic march is there, and the patient may have a history of having had other atopic symptoms sometime or the other in their life, or most of the patients have allergic rhinitis or obesity or obstructive sleep apnea or GER or something of that sort. So asthma is basically a multimorbidity. Then risk factors including severity of airflow limitation, practical issues including availability and cost of medicines, and potential adverse effects of treatment. One must elicit and address patients' and caregivers' goals also, as this may differ from the medical goals. So our aim is not only symptom control and risk minimization, but patient satisfaction is one of the most important aspects of treatment of any disease, and therefore we must address the same. A word has been added about the GINA regarding remission. Now it talks about remission under certain headings. First, it says that remission can be clinical, or it can be a complete, that is pathophysiological remission also. It talks about remission in children and remission in adults. It talks about remission of treatment and remission on treatment. So clinical remission is basically no symptoms of asthma and no exacerbations because of asthma for a specific period of time. And complete or pathophysiological remission means that there is clinical remission, but along with that the lung functions have also returned to be normal, and there is no airway hyperresponsiveness and no increase in inflammatory biomarkers. Asthma remission on treatment is the same as the long-term goal of asthma management, that is few or no asthma symptoms, no sleep disturbance due to asthma, and unimpaired physical activity in patients with asthma. So this is what GINA talks about remission in 2024. As we know, in GINA guidelines there are 3 age groups, that is 6 to 11 years, then 12 to 18 years, and more than 18 years. GINA generally does not talk about children less than 5 years of age, and there are 2 treatment tracks. First is the preferred treatment in any individual, And the second is the alternative treatment. Preferred treatment is the treatment which we hope will give the maximum results. An alternative treatment, if just in case the preferred treatment is not available at someone's place, then in that case we may give alternative treatment. This you can see in previous videos on GINA guidelines also, the links of which I have shared below. And this is the example. This is the first track, that is track 1, where it is referred, where the preferred controller and reliever medications have been written, and this is the track 2, where alternative controller and reliever medications have been mentioned. The new flowchart for initial asthma treatment includes the GINA cycle of asthma management as a reminder that asthma treatment is not just about medications, and this we are talking about adults and adolescents track 1. And this is the example which the GINA has given. This is the diagnostic flow, this is the flowchart of initial treatment which GINA has given, and here we see that this is the GINA cycle of asthma management. And one thing I'd like to point out over here, that initially the terms used were assess, adjust and review, but what the GINA in 2024 has made a change is that it says assess, start and then review the patient. So this is the GINA guide, the asthma cycle of management, and here you can see that one must on every visit assess the following things. First, you must confirm the diagnosis if at all it is required to. Assess the symptom control and modifiable risk factors, assess the comorbidities, assess the inhaler technique and adherence by the patient, assess patient and parent or caregiver preferences and goals. One must start inhaled corticosteroid containing medication. See, so much stress is on inhaled corticosteroids. Treatment of modifiable risk factors and comorbidities should be instituted simultaneously, otherwise proper asthma control will not be achieved. Non-pharmacological strategies for modifiable risk factors like smoking and obesity should be started as soon as possible. Besides this, education and skills training for the use of inhaler should also be started. And one must review symptoms, exacerbation, side effects of the drugs, lung functions, comorbidities and patient or parent caregiver satisfaction, which is also very important. Now, steps 1 and 2 of the initial treatment track have been aggregated as steps 1-2, since low dose ICS formoterol is the preferred treatment at both step 1 and step 2. So this is what I am talking about. Here step 1 and step 2. I think in GINA 23 also the steps were the same, but this has been mentioned separately, so I have written so. Steps 1 and 2 have been aggregated as one because as needed low dose ICS formoterol was the preferred controller therapy in step 1 as well as in step 2. In step 1, and the reliever therapy is also low dose ICS formoterol. So both these steps have been conjoined, like steps 1 and 2 are same as single step only. This is the preferred controller therapy for patients who have low frequency of symptoms. So when are we going to start the patient on regular low dose inhaled corticosteroid and formoterol? That is, when are we going to start the patient on step 3? When the patient has almost every day the patient is having symptoms, he has low lung function, he has recent severe exacerbation or a history of life-threatening exacerbation, he has impaired perception of bronchoconstriction. For example, low initial lung function, but symptoms are very few. So the patient is not able to perceive actually how much bronchoconstriction he is suffering from. Severe airway hyperresponsiveness, current exposure to seasonal trigger and current smoking. So these are the factors. If they are present, you need to start regular low dose inhaled corticosteroids instead of as needed, as in steps 1-2. The 2014 GINA recommendation of starting with step 1 treatment in those with symptoms less than 2 times per month and no risk factors for exacerbations has been replaced, considering the side effects of SABA only treatment. Also, the 2019 GINA has recommended against the use of SABA only treatment, and therefore the recommendation which 2024 GINA makes is that patients who have infrequent symptoms, here it is mentioned less than 2 times per month, here it is less than equal to 2 days per week. Basically here they are talking about nocturnal symptoms and here they are talking about daytime symptoms. So any patient who has, both are one and the same thing actually. So any patient who has infrequent symptoms, taking ICS when SABA is taken is preferred over daily ICS therapy with SABA, with as needed SABA, because patients who have so infrequent symptoms, that is less than 2 days per week, will not take daily ICS even if they are prescribed. That is, if they remain symptom free for most of the days, why would they take daily steroids? So it is better you give as needed, you give ICS only when the patient is taking SABA, so that at least compliance is maintained. In the treatment figure, asthma medications has been changed to asthma medications including inhaled corticosteroids, as a gentle reminder that all patients with asthma should receive inhaled corticosteroids containing therapy. So this is what I am talking about. The photograph is slightly blurred, but this is what the GINA says, that asthma medications include inhaled corticosteroids. Here again it is adjust. So what is important is that the entire stress is on inhaled corticosteroids, and inhaled corticosteroids. Medications and doses for track 1 anti-inflammatory reliever therapy have been clarified by GINA 24. This means, like in the previous scene you had seen, that the treatment chart consists of two tracks, track 1 and track 2, and in each track there are two subdivisions. First is for the controller therapy and the second maintenance and controller therapy, and the second is for the reliever therapy. So here the GINA has given the details about anti-inflammatory reliever therapy. Why is it known as anti-inflammatory reliever? Because it has two components. One is the steroidal component, that is inhaled corticosteroids, which acts as the anti-inflammatory agent, and second is the reliever therapy. The reliever part can be a short-acting beta agonist, or it can be a specific long-acting beta agonist with a onset of action as quick as a short-acting beta agonist, which is formoterol. So GINA has clarified the details about track 1 anti-inflammatory reliever therapy. What it has mentioned is that all relevant inhaled corticosteroid formoterol devices like DPIs and MDIs have been mentioned. So here, for example, it is DPI has been mentioned and pressurized MDI has been mentioned. Doses of AIR therapy by age group and treatment step has been mentioned. This age group is 6 to 11 years, this is 12 to 17 years, and this is 18 years and older. And treatment step, here step 1, 2, step 3, step 4 and step 5. Again step 1, 2, step 3, step 4 and step 5. So step wise the dosing has been mentioned. The corresponding dosing regimens, that is dosing regimens, are in step 1 to AIR only, no evidence of this thing extra in to date, AIR as and when required. In step 3, one inhalation once daily plus one as needed. So this is the anti-inflammatory therapy frequency regimen in step 3 in children 6 to 11 years of age, so on and so forth. You can go in detail and see. Then maximum number of inhalations in a single day which the patient can take. For example, a patient between 6 to 11 years of age, if he is using budesonide formoterol dry powder inhaler, he can use a maximum total of 8 inhalations in one day and 16 inhalations in one day if he is using 50 by 3 budesonide formoterol, which however is not available in India. So here we have, in India we have only 100 by 6, PMDI also is 100 by 6. So this is what it mentions about adding details about anti-inflammatory reliever therapy. Beclomethasone formoterol has also been recommended for MART by GINA 2024. As we know, the dose of budesonide formoterol MART in adults and adolescents is maximum of 12 inhalations in a single day of 100 by 6, that is a total of 6 into 12, that is 72 micrograms of formoterol can be taken in a day, which is equivalent to 54 microgram of the delivered dose. In budesonide formoterol MART between 6 to 11 years of age group, only 8 inhalations in a day can be taken at the maximum, which is equivalent to 48 microgram of formoterol. So when it came on to the administration of beclomethasone formoterol, here you see the LABA remains the same because it has the onset of action as small as that of SABA. In adults and adolescents also, beclomethasone formoterol MART has come into recommendation, and the recommendation is again of maximum 12 inhalations per day, because the dose of formoterol administered should remain the same, that is maximum 72 micrograms, that is 54 micrograms of delivered dose. If ICS formoterol reliever is taken with ICS non-formoterol maintenance, then it may be associated with an increased risk of adverse events. So, a switching over is not preferably allowed. A gentle reminder has been added to advise patients, parents, and caregivers about the potential risk of neuropsychiatric adverse events associated with the use of montelukast. So, this is very important. Left, right, and center, montelukast is being prescribed, but one must be aware of the fact that FDA has warned of certain neuropsychiatric adverse events associated with montelukast, and these include new onset nightmares, behavioral problems, and even suicidal ideation in some patients. High dose ICS, we are talking about high dose ICS, like we generally use low dose to medium dose inhaled corticosteroids, but high dose inhaled corticosteroids is recommended only for short term use in adults and adolescents, only for maximum say 3 to 6 months, to minimize the potential for adverse effects associated with high dose inhaled corticosteroids. GINA mentions that in patients with history of exacerbations in the previous year, triple therapy, that is inhaled corticosteroids, LABA, and long-acting muscarinic antagonists were associated with reduction in severe exacerbations requiring oral corticosteroids. So examples of these triple combination therapies are, and they are basically recommended for more than equal to 18 years. I've just mentioned, put in a word, beclomethasone formoterol glycopyrronium, where glycopyrronium is the LAMA, fluticasone furovate vilanterol, which is a LABA, and umeclidinium, mometasone indacaterol, and glycopyrronium. The highest priority is to reduce and cease oral corticosteroids even in severe asthma, if at all they are being used, and maintenance dose of inhaled corticosteroid formoterol should not be stopped even in patients with severe asthma, taking step 5 treatment even if they have a good response to biological. So the whole stress is that inhaled corticosteroid should not be stopped completely in patients with asthma. The initial GINA, in the initial treatment flowchart for children 6 to 11 years, the GINA cycloplasma management has been included in initial asthma treatment. As a reminder that once again, asthma treatment is not just about starting medications. Symptom level and lung functions prompting a particular starting treatment step are similar to those in adults and adolescents. Allergen immunotherapy may be considered as an add-on therapy for adults and children with asthma who have clinically significant sensitization to aeroallergens, including those with allergic rhinitis. So in this, what happens is that we are basically administering very small doses of allergen to sensitize the patient so that he develops antibodies against the same, and he develops immune tolerance against the same. So it basically involves identification of the clinically relevant allergens and administration of extracts in precisely calculated doses to induce desensitization and or tolerance. There are two approaches: subcutaneous allergen immunotherapy and sublingual allergen immunotherapy. Both are available in India at different places. Different approaches are being used. Allergens most often tested are house dust mite and grass pollens, with insufficient evidence about molds. AIT may be considered as an add-on treatment, but only and only after asthma symptoms and exacerbations have been controlled. So this is not a primary modality of treatment. This is for long-term control. A table of low, medium, and high dose inhaled corticosteroids alone or in combination with LABA does not imply equivalence of potency. So what GINA means to say over here is that the low dose of beclomethasone dipropionate is not equally potent as the low dose of budesonide. So I hope you are able to understand what I'm trying to say. So if you shift, now for example, if you shift from medium dose of one to medium dose of another inhaled corticosteroids, this may actually represent an increase or a decrease in the potency, such that a patient's asthma may become unstable or may pose an increased risk of side effects. There are certain other minute updates by the GINA. Mild asthma is a retrospective label, as I've already mentioned in the previous video, and hence it cannot be used to decide which patients are suitable to receive step 1 or step 2 treatment. So this term should not be used, mild asthma, because even in patients having so-called mild asthma, exacerbations can be severe. Pulmonary rehabilitation is recommended for improving functional exercise capacity and quality of life for patients with asthma, and is recommended in patients with asthma having dyspnea due to persistent airflow limitation because of permanent remodeling of their airways. Persistent airflow limitation is because of persistent remodeling of the airways of a patient. The main role of fractional excretion of nitric oxide in clinical practice continues to be of help to guide treatment decisions in patients with severe asthma. More information has been provided about vaccinations against respiratory syncytial virus, pneumococcus, and pertussis, and interventions to reduce RSV infection in infants. GINA says that in patients with moderate to severe asthma, patients with moderate to severe asthma should receive an influenza vaccine every year. Every year they should receive, or at least when vaccination of the general population in their area is advised. Encourage children, adults, and elderly with asthma to follow the local immunization schedule, including pneumococcal, pertussis, influenza, RSV, and COVID-19 vaccination. So yearly influenza has been recommended, but others have to be given as per the local immunization schedule. A word has been added about chronic rhinosinusitis with or without nasal polyps, which is of more relevance to the adults. OCS are essential in the management of acute severe asthma. Acute severe asthma is acute flare-up or exacerbation of asthma, in which case the administration of oral corticosteroids is recommended, but oral corticosteroids are not at all recommended for long-term control and maintenance of bronchial asthma remission. This is very important distinction which you must remember. Evidence about use of dexamethasone has been updated, like in a study in which oral dexamethasone 12 to 16 mg OD was given to children and adults with exacerbation. Relapse rates were similar to that found with oral prednisolone for 3 to 5 days. So not much of benefit of adding dexamethasone. And prevention of occupational asthma, a new section has been added because it has been seen that asthma may be induced or aggravated by exposure to other sensitizing agents at work, or sometimes from a single massive exposure, and early diagnosis prevents the worst outcomes in patients with occupational asthma. So coming on to the take-home points of the ready reckoners at the end, the important updates once again. Different initial lung function tests have been recommended by the GINA 24, which include both spirometry and PEFR in resource limited settings. Clarity on terms have been mentioned for cough variant asthma and cough predominant asthma. Cough predominant asthma will have other symptoms of asthma also, and cough variant asthma will have cough as the only symptom. Might not be bronchial hyperresponsiveness might be evident only on bronchial provocation testing, but what is important is sputum eosinophilia, and sometimes raised FeNO may be there, which may be a clue to asthma. Assessment should not only include symptom control but should also include the risk of exacerbations in future, any change in lung function, and adverse effects of any medication which the patient is on. The GINA's goal of treatment include not only long-term control of symptoms but also long-term minimization of the risk of exacerbations, which is very important. Remission, a word about remission has been added: clinical, pathophysiological, childhood remission, adult remission, on-treatment remission, and off-treatment remission. A composite step 1-2 has been added in the track 1 of initial treatment in adults and adolescents because as needed low-dose ICS formoterol is the controller and maintenance therapy in either of the two. Prefer step 1 in patients with infrequent symptoms. There is continued stress by the GINA on inhaled corticosteroids and continued de-stress on the use of oral corticosteroids, and oral corticosteroids are only recommended to be used in acute exacerbation and maybe in sometime in step 5 in patients who are adults or adolescents. Medications and doses of anti-inflammatory reliever therapy have been mentioned. Dosage of beclomethasone formoterol has been updated. ICS formoterol is not to be used as reliever with other ICS non-formoterol LABAs. There is a reminder to the patients and the caregivers not to use montelukast very frequently because of the risk of neuropsychiatric adverse events and for a long time. High dose inhaled corticosteroids suggested only for very short term duration, that is 3 to 6 months in patients with step 5. Triple therapy has been associated with reduction in exacerbation risk requiring oral corticosteroids. Highest priority is to stop oral corticosteroids, but ICS formoterol should not at all be stopped even in patients with severe asthma who are controlled with biologicals, etc. Oral corticosteroids need to be given only in acute exacerbation. Allergen immunotherapy may be considered as an add-on treatment once the symptoms and exacerbations have been controlled completely. Table of low, medium and high dose inhaled corticosteroids alone or in combination with LABA has been added. The term mild asthma is to be avoided because even mild asthma can have serious exacerbations. Pulmonary rehabilitation is recommended for improving functional exercise capacity. FINO is used to guide treatment decisions in patients with severe asthma, and patients with moderate to severe asthma should receive an annual influenza vaccine and other vaccines as per their local immunization schedule. So this was all from the GINA 2024. Thank you so much for a very patient listening and watching. I guess this has been the longest video of mine till date because so many recommendations were there and one needs a clarity on the subject because there is a deficiency of videos on GINA 24. So thank you so much once again, and in case you like the video, I would request you to give a thumbs up and share the video, subscribe the channel, and do let me know if you have any doubts in the comment section below. Thank you. Thanks a lot.